Well, good evening, everybody. Welcome. Thank you for joining us for Everyday Endo with EdgePRO. It's a summer series exploring the application of EdgePRO technology for advanced cleaning and disinfection. This is part two of our three-part series. Part two tonight, we're going to discuss mastering technique and extending applications with the EdgePRO technology. We're really fortunate to have you all here. Many of you are EdgePRO users that have started to incorporate the technology into your practice, are coming tonight to listen to some experienced users, maybe gain some tips and tricks and or ask some questions around some of the experiences from our faculty. Others are exploring the technology, and we urge you similarly to ask any and all questions. Our format tonight will be each of our faculty presenters will present roughly 15 to 20 minutes. But I would ask that you please think of your questions. There'll be a questions tab that you should see on your screen. Please tap that tab and if you would go ahead and type in a question. I will see those questions, we'll collate those questions and be able to ask them of our panelists towards the end of the program. So we thought we'd go ahead and get started. I'd like to go ahead and introduce our faculty. We're very lucky tonight. Remember from part one, Dr. Charles Maupin from Maupin Endodontics in Lubbock, Texas, kicked us off. So Charles is joining us again this evening. Thank you, Charles. We also are very fortunate to have Dr. Craig Anderson join us from South Mississippi Endodontics in Biloxi, Mississippi. Dr. Anderson has also had a vast experience in incorporating advanced cleaning technologies into his practice. Fairly recently has incorporated the EdgePRO technology and erbium chromium YSGG technology into his practice. And we're very fortunate tonight to have him here to share some of his experiences. And then lastly, Dr. Jacob Butler from Wichita Endodontics in Wichita, Kansas. Dr. Butler, similarly, also experienced in this field, has employed the technology for about a little under a year. And we're really fortunate to have him here to share his early experiences and really talk a little bit about how it's worked so well within his practice. So without further ado, I'd like to pass it over to Dr. Maupin, who's going to kick us off. Again, please think of those questions that you want to ask of the faculty, of specific faculty members and or the panel as a whole, and we'll make sure all those questions get addressed. But we welcome you and thank you again for joining us. Dr. Maupin.
Hey, thanks, Chris, for the intro. And, I think this is a pretty cool little layout that Edge has done, with myself and then having Dr. Anderson, Craig, and Dr. Butler on here as well. And so I was pretty excited when they put this together. And what I want to do today is I just kind of want to focus on the mastering the technique. And so for some of you that were on last month, some of this kind of may be a repeat, but I think this is the important part of it. This is what the EdgePRO was designed for, was for the endo applications. And, when I go out and talk to people, kind of some of the stuff that I hear is, well, how are you getting those results? How do you do that? And so the key focus is, to sit down, become comfortable with it, and to use it for every case. Use it often, use it early, all day, every day. Excuse me. And that's when you'll start achieving the results there. So we're going to focus on, like I said, the mastering the technique side of it. So kind of, this is pretty basic here, and we don't have a lot of time here, but we're going to go through a few things here. The goals of endo treatment, what are they? We all are familiar with this. We know it is to eradicate all biofilm and bacteria, to remove the pulp tissue, to removal of any further irritants to the apical tissues and supporting bone structure, and then lastly, to obturate to the canal terminus. I think that's, kind of what we want to do there is our goals, to summarize that. And I realize it's more nuanced than this, but to put it in simple terms, it's to get from point A to point B, as quickly, efficiently as possible. But, along the way, anyone that's done endo treatment, hurdles occur along the way. Separated instruments, how about a ledge, apical blockage, apical transportation, continued apical drainage there. So, anyone that has done any type of treatment has encountered any of these, 5 things listed, and this isn't all encompassing. There's other stuff that can go on as well. And what does that lead to? And what that leads to is frustration in there. And, anytime we're trying to get from point A to point B and we have these hurdles, we get frustrated. And what happens when we become frustrated? Well, if we look at anything in life, let's take diet, exercise, or something. We have goals that we want to achieve. And for instance, today I was working out and my power went out at my house and in my shop, lost complete power. It was 106 out and lost power to my fans in there. So it was really hot in the shop. Real easy to just kind of throw in the towel on that stuff, get frustrated with the situation, move on, or you can continue to kind of work through that. Now, again, pretty basic example, but same thing in endo. We have a case, we're struggling with the case. We have difficulties, we ledge, we can't get to length, we can't achieve patency. Then what do? We end up settling, we give up, and we end up with a short fill, and then we try to rationalize that. Well, I tried my best. This was the best that I could do here. And, I think that, we've all had that. We've struggled with it, but we shouldn't accept this as our treatment here. And so when we move from point A to point B, what we want to do is we want to get there as efficiently as possible and accomplish all the goals that we listed earlier that we have there. And so without question, when I incorporated the EdgePRO, I started to see a difference there. And when I go out and talk to other people, what I see and what I hear is when they become familiar with the technique and they utilize the technique as we talked about, is they say, hey, this has definitely made cases easier for me. And again, I'm not here going to say that it's going to solve all your problems, but it's going to make cases simpler, more efficient. And typically what I hear is, hey, cases are about 30% easier. Canals look cleaner macroscopically through there. We've done some SCMs and they also look cleaner through that right now. So we move from point A to point B in a more efficient manner. I think now, if we can only accomplish that with other parts of our life, some of that's just, you got to grind it out. Again, what I'm going to do is just talk about kind of the technique of it today, and then I'll pass it over to Dr. Anderson, Dr. Butler, and they'll kind of share their experiences with it as well. But my guidelines are to incorporate the EdgePRO as early as possible into the procedure. Necrotic teeth, as soon as I access, I'm bringing it in. I'm running through that. We'll go through that in a minute. It aids with removal of organic debris. It facilitates instrumentation. That's what I just talked about earlier. It makes cases, 30% easier. Helps to minimize transportation of debris apically. Helps prevent the flare-ups. You're gonna see decrease in post-op pain. You're gonna utilize the EdgePRO in between file usage. That prevents the accumulation of the inorganic debris into the isthmuses. It keeps that area clean as well. Just what we talked about right there, prevents that buildup in there. And, this case here I did today, just to kind of show the efficiency. Premolar is what I did here. You can see deep split apically going on. Last case of the day here, and didn't want to be tight on time here, but made the case super efficient. You look at this, you're like, well, maybe there's a third canal coming off there. Post-op CT just to confirm and show everyone 2 canals in there. You can see we maintain the fidelity of the canals, and then we have the buccal and the lingual canal there as well. And so, these cases can be tough. They can be frustrating. They can be challenging. And as it worked out yesterday, I also had a 3-rooted, this was 3-rooted premolar, the other one was 2. 3-rooted premolar in the day. Kind of split off on the MB and DB and then the single palatal canal there. Again, went in with the laser, accessed, cleaned everything up, could see the canals, could see the bifurcation of the buccals there, facilitated instrumentation, made the treatment of the case much simpler, much easier. So the guidelines here that I use for every single case, the tip number 2 and the tip number 3, I utilize in the chamber only. I use this with solutions or water, depending upon the case. And tip number 1, I only take to mid-root. Some people like to take it all the way to the canal terminus or 1 millimeter short. My recommendation is to mid-root and do not go past curves with them. Solutions or water only as well. And then there are some presets that come with it for lower anterior teeth with very small access openings. That's what I did on a couple of these today. You're going to lower the wattage down there. So rather than running at 1.5 watts, you may be at 0.75, maybe 1. But you want to make sure there's always some type of solution in there. So if you have it up too high, solutions popping out of the canals, lower the wattage down there some. This here is my vital protocol. Instrument, as soon as I access, take a 10 file, see if I can get patency with that, confirm it, instrument to a 1704 prior to introduction of the EdgePRO. And then I'm going to go through the coronal conditioning using hypochlorite, 1 watt, 50 hertz. Then I'm going to go to the canal disinfection using the #1 EdgePRO. And in between the coronal conditioning and the canals, that's when I'm instrumenting. And then I'll go to the canal disinfection and then a final rinse with the coronal conditioning, 2 watts, 20 hertz, 90% water and air off. The only difference between the necrotic protocol is I come in and I just use water. Immediately after access, I blast for about a minute, 2 watts, 20 hertz, water only. Some people like to come in with hypochlorite. I'd drop it down to the 1 watt, 50 if you did that. But I use the water only just to flush everything out, go from there. Instrument canals to a 1704 for small, 17 to 20, and medium large is a 20 to a 30 is what I'm doing on that now. So I am going a little bigger on some of these now, but that's kind of my regimen there. And the reason I'm going a little bigger is looking at some SEMs. The slightly larger ones with the even with the laser look a little cleaner on them than the 1403s or these small instrumentations that I've done. So I've kind of been both ends of the spectrum there. Canal disinfection using #1 EdgePRO, like I said, 0.75 to 1.25 watts, 50 hertz. Air and water's off, fiber taken a mid-root, and then your assistant's going to fill the chamber with solutions, or you can fill it and toggle it back and forth between the two. Final rinse with water. So I think what I heard from the last one, for those that couldn't, that were not able to attend, is that these videos really help to drive home the technique and being able to visualize it made it easier to go back and employ, tomorrow in the op when you're there. So image on the left is before any treatment was done. You can see the caries there. Image on the right is cleaning caries up and access into the canal, and you can see the liquefactive necrosis going on there. And so immediately after this step right here, we went in and we did the coronal conditioning, and that's what you're going to see in this video here. And so on here, on this video, I'll point it out in a minute, but if you'll just watch a few minutes in, you're going to see a chunk of tissue come flying out of the canal, and you'll see this when you go in there and do it. Here it comes. I slowed it down, and there it went right into the suction. So, instead of pushing that apically, going to run it back here one more time for you to see. Instead of pushing that apically, if you go in with instruments only, we're flushing all that out. And then that's what, and if that's in there, that's clogging up your instruments. So you can see how much easier with that being out of there it is to just pass your instrument down to the, achieve patency. Once you get working length, we all know it's getting point A to point B. It's pretty simple. So that's a coronal conditioning step there. And image on the left, again, is immediately after access, and that's that, liquefactive necrosis. Image on the right, I use some little cool dam on there, and you can see this is before any instrumentation. This was just running the laser with the water only there. How clean the canals are. You can see that little isthmus going on in between them as well, cleaned it out. So then we went through and instrumented, and now we're coming in here. We have our #1 tip, and I've got water on right now. And this is just kind of in between the instrumentations. I go in there with water. You can use solutions as well if you like. You're kind of in control, and you can determine what it is that you want to do, for each individual case. My assistant's keeping my mirror clean so I can see. So you're going down to mid-root, and then you're slowly withdrawing the fiber 1 millimeter per second roughly. And then when I come out, and I'll show you again here in another video, when you come out, you're going to hold the fiber kind of right at the canal orifice there. So what we have going in here now is our solutions. So in this one, I'm going to fill them up rather than do a continuous fill. I'm going to fill the canals up each time, and then we're going to toggle it back and forth past the handpiece and the hypochlorite or the EDTA in there. So I'm going in one canal there. You'll see the solutions kind of bubbling up the other. When you're in the scope, you can see the solutions popping out of the tooth. It sends it up and out. And then I'm going to hold it right up at the top. You see how I pull it out and then I hold it for about 10 to 20 seconds right at the orifice level, right out of the orifice. Now, when you're inside the canals, you do not want to hold the fiber in one place. You always have to activate on the outward stroke of it. And then once you're out, like I said, you hold it in one place. Coming back again with solutions, same thing again. And, I think the recommended one is they say, 3 times per canal. But again, some canals need more, some canals need less. I think, anyone that's done endo knows this. Some require a lot of, instrumentation and irrigation, and other ones not nearly as much. But 3 is kind of the starting point, and then you go from there and build it from there. Going back in again, activating, holding on the way out. And we'll continue. I'm going to speed this up a little bit, sake of time. And then we aspirate and we're ready to operate the case. And so now, in comparison to the image we saw earlier, we can see, this is minimally instrumented. You can see how it cleaned the isthmus out in between the two and kind of, remove some of the calcification in there. And this was the image on the right, was the image before. Right after access, just water only. Image on the left is after a little instrumentation and then going through all the solutions. You can see how much cleaner it is. Then we have the post-op. We got some lateral canals going on. I did a little gingivectomy going on there with the tissue just to make it easy for restorative, and then restored the case. So pretty straightforward case. Here's a molar. Again, pretty straightforward. Image is before any treatment's done. You can see the caries going on, access. And what I want to show you for efficiency, for those that haven't seen this, I take all stops off when I know my working length, and I just use the lines on the files. And then my assistant is rinsing my file off as I go. And so it's very efficient. What I want to do is I want to spend less time. I want to get my shapes cut inside the tooth, and then allow the laser to do the disinfection phase of it and the cleaning and everything. So, if I'm not having to sit there and peck and wipe, with the 2x2 gauze that we used to do, she just rinses off, clears the debris from the flutes, and then you can go in with your next one there. So that's kind of what I was showing there, just how efficient that is. Then we're coming in with our laser here, and solutions in the tooth, we're activating, and then we're holding at the orifice level. We're in the distal canal here. Going back down, let off the gas, and then activate on the way out. And then as I go in the MB canal here, you're going to see a little heme come out of it first. And there was a little resorptive defect going in there. And so what you're going to see here, first time, some heme coming out. We're going to flush that out. And then notice the difference here when we go back in. Just a second. So I'm going in the mesiolingual, activating. And the syringes that I typically use, if it's a molar access, I just put an etch tip on there, just fill the chamber up. If it's a small one, then I'll put the 27 side vent needle or something on there. We'll go back in there now. You can see there's really no heme coming out of it now. So cleaned out that resorptive defect, and you're going to see that on the post-op image here. You'll be able to tell where it was there. Activate, hold at the orifice level, go into mid-root, activate, hold at the orifice level. 10 to 20 seconds, just keep it there. In the distal canal, go in, activate again. So I'm just going through all the canals, activating and holding. Now, I will tell you, there will be some times, this is kind of the beauty of the EdgePRO, is you can go inside the canals or you can stay in the chamber. And you get an upper second molar, that minimal opening, patients, it's distal buccally inclined. That's where that number 3 tip is a lifesaver. And you just fill the chamber up and you activate in the chamber, and you're doing that there. The distance from the tip, distance is basically the enemy. So the further you get, the less activation you have. but it still does a great job being in that chamber. But if we can get down inside the canals, much better off. And again, I think that's the beauty of the EdgePRO is you get to do both. So now we're coming back in doing our final coronal conditioning. I just left the number 1 tip on here. I do this for about a minute. We come in and I just hold it, roughly orifice level, kind of move it around in the chamber, flushing everything out. Angling towards the other mesial canals. And then after that, we're ready to aspirate and dry. And so you can see here on the image on the right, we see that little resorptive defect manifested there, but we've got, fill to the canal terminus. We got a little accessory canal coming off in the apical third on the mesial root there. We did, again, a little gingivectomy on this one to aid with restorative treatment there. So pretty conservative shapes, but not, the super conservative that I once was doing 1403s. I kind of like this 2004, 2006, the V taper file as well on these cases there. Here's the post-op CTs going on. You can see the accessory canal there, manifest there as well. And what I've talked with a lot of people, they're like, well, you're not doing the 1403s anymore. You're opening it up. What are you doing different now? And so I'd like to share this little Zen proverb: before enlightenment, chop wood, carry water. After enlightenment, chop wood, carry water. And so, I think we could change those. We could say before enlightenment, I cleaned the canals and I obturated them. After enlightenment, I cleaned the canals and I obturated them. But we're in a different mindset now. With the incorporation of the EdgePRO, it's really changed, how I'm thinking about each case, how I'm approaching each case, the amount of time, the efficiency involved with it. So, some people may seem like we're doing the same thing, completely different mindset going on there. And it's been, helping me move from point A to point B. I mean, a total game changer for me. So with that, I'd like to pass it over to Dr. Anderson and let him take over.
No. All right, Charles, thank you very much for the introduction. Let's see. How are we looking there, Charles? We got my screen up?
There we go.
Okay,
looks
great.
Good.
All right, perfect. Thank you. Thank you, Charles, for the introduction. Thank you to Edge Endo and to Chris Rabbit specifically and Chris Bailey both for inviting me to be on this panel. I really appreciate the opportunity. For those who don't know me, my name is, excuse me. Let's see. My name is Craig Anderson. Just a little bit about me for those who don't know me. The important stuff here, I'm from Mississippi. I went to NYU for endo school, finished in 2009, and then moved to where I am now in Biloxi, Mississippi. Started a private practice where I've been practicing ever since. We have a big busy practice, 2 locations, 3 endodontists, two full-time, 1 part-time, and I say that for this reason. I am a practicing endodontist. I'm in the trenches every day. I am not an academic. I am not a laser scientist. You're not going to get anything from me that tells you the nitty-gritty on how lasers work or what they what they are actually doing in there. Everything I'm going to talk to you about is is how I utilize it in my operatory and how I use it in everyday endodontics. And then the last item listed there is I do a lot of teaching online as well, so you may have seen a lot of my cases, even if you don't maybe know who I am. So this is a funny topic to lecture on for me, especially following Charles, because pretty much everything I know about this topic I learned from Charles, not just tonight, but he's been a wonderful mentor to me, a good friend, and I've bothered the heck out of him over the last year and a half to get ideas on how to utilize this technology. And so he did a great job presenting, more the nitty gritty of how he utilizes the technology. And, you're not going to get quite as much detail from me. Mine's going to really be more, really based on my kind of where I came from and where I've evolved to over my career, with not only with the laser, but also with other enhanced irrigation. So very quickly, I won't belabor this point too much. I think the audience is mostly endodontists, so you guys will know a lot of this. But I think it's important to know kind of how we got to where we are. When I finished NYU in 2009, and I was trained, very classic kind of classic endo technique, standard access. At the time, I was, pro tapers were the file du jour, so I was, S1, S2, maybe finishing F1 or bigger, with very little consideration for preservation of tooth structure. My cases were, very formulaic. I imparted shape on teeth the way that I was taught. I'm going to have big shapes with little thought to what that might be doing for the tooth long term, in terms of whether the teeth are going to be viable long term from a structural standpoint. At the time, we were doing standard needle irrigation with endo activation. At the time, I was restoring some of my cases, but not all, and I had primarily a 2-visit practice model. I was lucky to get in some really great mentors when I got out, and primarily through TDO, but also other places as well. That's where I met Charles, and people like John Cotomy and Gary Carr were really instrumental in my life, and especially my practice life. And I consider myself really lucky to have a front row seat for the principles that would kind of evolve over the last 10 years to become MIE. And so that was a really exciting time, and I really dug in and sunk my teeth into it with everything I could to get better, get smaller, implement these ideas into my practice. And that's what I did, and I felt like I became a much better endodontist for it. So, over that time, obviously we introduced the CBCT, really got into dentin preservation, especially pericervical dentin, began to make more restoratively driven accesses, and then just really started trying to minimize our shaping, tried to impart less shape on the tooth. For me, that was moving away from Pro Taper and into what I still use today, which is the Edge Endo X7 files. They're nothing fancy, but man, they do the trick. They don't break. They're just fantastic files. I've used those a long time before I had any relationship with Edge Endo. Okay, still using needle irrigation with endo activator at this point, but I have moved into restoring all my cases. But probably the biggest issue still is I'm mostly a 2-visit practice at this point. Okay, and as my practice is getting busier, it's becoming increasingly frustrating. While I feel like I'm turning out better endo, I'm hearing from patients they really don't want to come twice, and it's putting a little more pressure on my practice. So I'm looking for ways to maybe move to a more 1-visit model, and that's where enhanced irrigation comes in. And so with enhanced irrigation, we're able to take the principles from MIE and maybe try to move the needle even further down the road. That's a little bit what I think Charles was mentioning when he was talking about 1403 shapes, some of these really small shapes. And I think that's where I thought I was going when I went to enhanced irrigation. I thought that's where I wanted to be. I'm going to really see how far I can push this, and I did for a while, but over time I found myself maybe coming back a little bit. And so that the last bullet point down there is kind of where I am now. I'm more of a modern enhanced endodontics. Okay, so it's the same as the modern endodontics, but we've added the enhanced irrigation. We've kept all the other principles, but now we're able to clean it more predictably, more efficiently, better, just all the way around. And because of that, it's giving me the confidence to move into more of a 1-visit practice. All right, so as we move into the irrigation, and I think this is something we just can't forget about, right? This is what we're up against. We get so in the mindset in our training, and when we look at just most root canals, it's these little white tubes, and we know that's not true, right? And even though that's what the white lines show up as most of the time, we know that's not what we're trying to clean, that almost all of our cases are going to have some of this exotic anatomy, and we've known this for a long time. We've known it for decades. And so with that in mind, it's kind of comical to think back on what we've been arguing in the AAE about for the last 30, 40 years about what file size or shape is better, when all along we know we're not addressing the other issues that are really in play here. So for me, enhanced irrigation, you know, in my practice, enhanced irrigation means Gentle Wave and the EdgePRO laser. I did not go straight to the laser. I started off with a Gentle Wave. For full disclosure, I still use a Gentle Wave. I'm a satisfied customer. I think it has a place in my armamentarium. And I don't know if I use it every day, but I use it certainly every week, at least a few cases. The reason I made that jump was, as we just mentioned, I knew that there was I could do better. I knew there was another level that I could, a way to level up, if you will. Okay, so I knew that as my shapes got smaller when I was doing MIE shaping, I knew it was working in the short term. I knew my patients were feeling better. I knew I was getting resolution of lesions, but something in the back of my head just kept telling me, man, I'm not sure if we're really getting this as clean as it should be. So I wanted to compensate for that feeling that I had, right? I wanted to try to push myself further. I wanted to see how small I could get, where I could take this. I wanted to try to reach all that anatomy that I knew that I knew was present based off that previous slide. I was looking to make cases easier and more predictable. But the big one here is highlighted in red. I really was trying to see if I could get the same results and move to a primarily one visit model. I'm always looking to get better, so I was hoping that this would help me reduce failures. I had been hearing reports of reduced post-op pain, and quite honestly, there was a little bit of FOMO. You know, a lot of my buddies are doing it, and I didn't feel cool, and I didn't want to be left out, so I got me a Gentle Wave. And I used the Gentle Wave I still use it, but I've had it for about 3 years, and I was a satisfied customer. But what I found was there were kind of some gaps in it, in how I used it. You know, if you guys, I'm sure you've heard, but you know, there's a lot of talk of, you know, is there going to be extra bleeding? You can't use it on certain case types. You can't use it if the apices are outside the housing, or if they're in the sinus or too close to different anatomy. So I'm kind of a wimp, you know, I'm not a cowboy. I'm not the guy who's going to do these exotic procedures and not be worried about it. So I just found myself not using it in a lot of cases out of fear, if you will. I also, you know, in cases maybe where a patient has limited opening or where the tooth is severely broken down, it was kind of a deal, right? It wasn't user-friendly in some ways. And so because of that, I just found that I wasn't using it as much as I wanted. And as the practice evolved, I'm marketing to my referring dentist that I'm an enhanced irrigation practice, and I'm not using it all the time. So I felt a bit like a fraud in that regard. And so I knew I had to fill in those gaps. Additionally, I have a partner or associate, and we were having to share this device, and he's not loving Gentle Wave even as much as I am. So we're looking for a way to kind of find our way to a better solution for our practice. I'd already made a pretty big investment in Gentle Wave, so you know, money's not endless. So I wanted to be conscious of price. So that was one of the big advantages of the EdgePRO. How I use my laser, I'm definitely not as far along in this as Charles, that's for sure. You know, listening to him, I'm learning a lot even tonight, listening to him and how he utilizes it. I am much more vanilla in my approach, and I think that's the beauty of the device. Unlike the Gentle Wave, where you kind of use it a certain way. You know, this is the protocol, and I think for that there are things about that are really good. I think that's a good thing for that device. But the great thing about the laser is you can use it however you want, you know, within reason, you know. And for me, I'm much more at this point, and it's evolving, it's changing. I'm branching out a little bit, but I'm very vanilla in the way I use it. Okay, I use it primarily as an irrigation device. I do very little else with it. And I basically do the cases like I always did. I've now added another step where I do this enhanced irrigation in my hands mostly towards the end of the procedure. Okay, I still also use it in addition to just helping me, you know, do the cleaning that I want. I can use it for other things. I'm going to show a case later where I couldn't get patency, and it helped me get the patency and helped me get, you know, I can get obvious sealer out beyond the terminus that I wouldn't have been able to get mechanically. And so it certainly does that too. I can use it, in the chamber mode to help me find, I've used it to help me, clean debris and help me find an MB2, for example. And I have used it a little bit, and I'll showcase in a little bit where I can use it for soft tissue management. Okay, so this is my basic protocol. Again, compared to what Charles just showed, very, very basic. Okay, but I will access the canals, access the chamber, locate the canals, do a little bit of coronal enlargement, establish working length, and I'll do my basic shaping just like I always did to whatever my MAF is. For me, that's typically 2004 or 2504 for smaller canals like the buccal canals on upper molar, or up to a 3006 or even a 3008 for larger canals like the palatal canal of an upper molar. Okay, for me, then I will go into a coronal disinfection with the number 3 tip in the chamber, just slowly around the chamber, staying off the floor for about 60 seconds. For a long time, that's just all I did, and then I moved on to the next step. Now maybe I might do that multiple times. I might go to the second step, and I might do a final rinse and come back to this later. But my base level protocol would be to use that for 60 seconds. Then I would move into using either a number 1 or a number 2 tip into the canal. Primarily at this point, it's almost exclusively a number 1 tip. Charles mentioned mid-root. I probably am trying to get a little further than that, I aim for maybe about 5 millimeters from the apex. Obviously, staying away from curves and things of that nature. Charles did a much better explanation than me, but engaging as I slowly withdraw. And I have implemented recently, starting to leave that tip above the orifice for a little bit longer, and then with my assistant in the scope replenishing and suction. And then I'll finish the case, final rinse, obturate, and restore. This is a case that I did for a lecture I gave to my general dentist in the area about enhanced irrigation. You'll bear with me if you don't mind. Let me real quick. This is doing the chamber mode. Let me see if I can back that up. Sorry. As I mentioned, this is a lecture for my general dentist, so it's going to show the whole root canal sped up because I wanted them to know that this is how it fits into my protocol. So here I'm running the laser in the chamber right there. Now we're doing a little more coronal enlargement. Standard irrigation, microsuction. So bear with this. I'm going to get working lengths real quick. As I mentioned, I was trying to show the general dentist exactly how this fits into my practice. But for this audience, what I think is the key to the laser is it just fits right in. It's easy. Nothing changes if you don't want it to. You can just do your normal cases and add this extra super benefit that's going to turbocharge the case, right? So again, still getting my working length. I'm not as new school as Charles. I'm still using my rubber stoppers. We're going to go 1704, 2504 for my buckles, as I mentioned earlier. And then here in just a second, we'll switch over and we'll get the palatal canal, 3006, 3008. Now we're going to shift over and start using our laser. You will start to see me placing the laser tip in, withdrawing, lots of debris and heme coming up there. It's a little fast there, but I think you get the picture there. That's MB, moving into MB2. And the palette there. Must have edited out the DB, I'm not sure. And then we got cones, and that's the final result, okay? This is a case that I just did today. I'll show you the results here in just a minute. Like Charles, lower premolar. This one has a 2-rooted / C-shaped canal, lots of nooks and crannies, 23 millimeters long. You can see me now in the lingual canal, tooth number 29, my assistant's irrigating. The lingual's not a lot of debris, but when you see me in just a second, I'll switch to the buccal. And you just watch this plume of debris and heme that come out right there, right? It kept going and every time I do it, I would get more and more out. So there's a lot of area where there was tissue hiding in that spot, okay? Again, I think that's a little zoomed in version. This was a pretty difficult access for my assistant. I need to get better with what Charles was talking about with just filling the chamber and not necessarily replenishing the whole time because my assistant was really struggling to keep her tip. kind of where I needed it. A little more, you can see the discharge of heme and debris from the buccal. Okay. I did mention I also do some soft tissue management. This is the same case. So we're using the laser to kind of obliterate the gingiva there to stop some bleeding. It's really hard to keep in frame. Bear with me. We'll zoom in here a little bit. So it looks really ugly there. But as you see the final result here in a minute, once I put water back over it, it looks really nice result there. No, it never started to weep or bleed again through the entire restorative process. So really helpful. I typically have used System B for that purpose, and I still do some, but I'm moving to the laser more and more as I'm getting results like that. So I'm going to just go through just a couple of cases here. You know, I think a lot of the motivation when I talk to people online is they think they want to get a laser so they can get more lateral canals and isthmuses, and I don't disagree with that. I think that is great. That is a good enough reason to get it, because if you're seeing that kind of anatomy, it means you're cleaning into more areas. I think there is a bit of an illusion that if you get either of these technologies, gentle wave or the laser, you're going to get lateral canals on every case and everything's going to look crazy and exotic, and that is, I don't think that's the case in general. Certainly is not the case for me. Maybe others will disagree, but it does help, and I do think my cases look better. They do have in general more anatomy, as you can see, if you can see listed here, okay, or you can see in these x-rays here. This slide's a little more dramatic. You can see lots of webbing here on this upper molar. These lower molars here with just tons and tons of anatomy in the mesial root. I really like this case on the upper right corner. This is by my associate, Jeff Loberg. You can see tons of communication between the buccal and lingual roots with a big apical delta at the end. And then just really just the amount of anatomy that you pick up is pretty startling. And then finally a lateral canal. But this slide is, I probably am even more interested in, and this is probably what more of my cases look like. You know, I don't know that I'm getting that kind of lateral anatomy, exotic anatomy all the time, but I know this is my bread and butter endo. I'm doing this all day, every day. But it may not look different, as Charles mentioned with his analogy, it may not look different from the chop wood, carry water, but I know it's different. I know definitively that it passes the eye test. I know that while the cases may look basically the same, they are indeed much cleaner. And while I don't have any papers to back it up, and I don't have long-term trials or studies to say that it's better, it has to be. You know, nothing is worse off being more clean, and I know that these cases are cleaner. So this is the case that I just mentioned earlier. This is that lower C-shaped tricky little case that I did today. I showed you the video on earlier. You can see, you know, we've got what looks like one big canal here, and then it just disappears. You don't even know, you know, is there 1, 2, 3, who knows? And this is the result, okay? It was, I think I mentioned 23 millimeters. I got patency in the buccal, but the lingual wouldn't really meet up with the buccal, and it was getting dinged up. I wasn't getting good patency, but you can see lots of accessory anatomy here, mid-root. We've got a little bit here, and an apical delta down at the bottom. To invert the image, it shows up a little better here and here. So, you know, this is the type of case where having the laser is invaluable. I just, you're not going to convince me I could have gotten that result and clean that the ramifications of that canal without a little bit of help. So, so with that being said, thank y'all for listening. That is my, you know, kind of my basic experience over the last year and a half with the device. I feel I'm really excited about where this goes in the future, because I'm really just now getting my sea legs under me and starting to branch out a little bit and trying different stuff. And I think the future is really exciting with it. So with that being said, thank y'all very much, and I'll turn it back over to the rest of the panel.
Dr. Anderson, before we pass it over to Dr. Butler, one question for you. How do you decide to use EdgePRO or gentle wave in a particular case?
You know, as I mentioned, I do teach online a lot, and that's probably the number one question I get. And I've answered it so many times you would think I had a better answer. There's a multiple reasons. You know, is my associate using the laser? It could be as simple as that. You know, I don't have access to the laser. Somebody uses general wave. That's not the most often reason. It's really gosh, for me, mostly when I use the general wave is when I'm working to a crown. If I have a really nice access, super easy, straightforward case, perfect patient, where I don't have to worry about, you know, getting the device in there. There's no issues in that regard, and I'm not gonna have to worry about a big buildup issue where it's just easy. The general wave works really good. I can use it anywhere. I mean, I can use it on broken down teeth, but it's just not as convenient. You know, the laser is so convenient for me, and as my practice has grown and gotten busier, I'm just trying to get through the day, right? So I'm not sure I answered it perfectly, but I tend to use the general wave a lot through crowns, standard occlusal accesses where there's not a lot else going on, where it's just going to be kind of an easy case. I will probably err towards general wave on a real legit C-shaped canal. I've just had, not that laser can't do it, I just had such good results with the general wave on really nasty, deep finned general C-shaped cases. So for whatever reason, that's still my go-to in that regard. Yeah.
Great. Thank you.
Mm-hmm.
We'll pass it over here to Dr. Butler, and then of course, please remind you, as you have questions, please type them in. We'll make sure that they get addressed as we continue to go forward. So thank you very much, Dr. Butler.
All right. Hello, everyone. Thanks so much for sticking with us to the end here, the last presenter. Just truly an honor to be presenting with Charles and Craig tonight, and thanks to Chris for inviting me on. I started residency back in 2016, University of Detroit Mercy, and my co-resident, David Sellis, I remember he was up to date on all the latest and greatest, and he was able to show me who to follow on Instagram, and definitely was able to see Craig on there and follow him for many years. So it's an honor to be presenting with him. And then just met Charles up in Chicago at the AAE 2023 this year, and was able to hear from him and see how he utilizes the EdgePRO laser in his practice. So definitely learning a lot from these guys, and like I said, it's an honor to be presenting with them tonight. I also, like Craig said, I'm not an academic. I'm not going to try and explain the the nuances of the science behind using the laser for as far as the science goes and disinfection and everything like that. I'm going to show my real world experience, how I'm utilizing the laser in my practice, and how kind of things have changed, why I incorporated the laser, the EdgePRO laser in the first place. So my initial thoughts, the reason why I started being interested in using the EdgePRO in the first place was because I thought it would be great for the tough cases. I wanted to use it for the cases that we've seen tonight and in the previous presentation, the difficult cases. I just kind of my honest prior opinion, I thought that it would probably slow down my workflow. I didn't know how much. I thought at least a little bit, and maybe quite a bit. I was definitely thinking that the patients would like it. I thought that they would enjoy it. And I thought that they would think that it was cool to be able to just kind of see that there was a laser being used in their mouth, or kind of like hear the machine and think that something extra fancy was going on. I also thought about my assistants. I'm always thinking about them. They're the ones that are kind of in the trenches and doing a lot of the hard work. And I thought, they're not going to love me for wanting to incorporate something, yet again, something new into my practice. I started using the EdgePRO back in September of 2022, so it's been almost a year now. And just kind of maybe my personality, but usually when I see something that I think has potential, I like to just kind of jump right in and try it out and get my hands on it and see how I can best utilize it to help me and help my patients and help the just the cases that I'm doing turn out better. And so I'm not going to go into the protocol and techniques, that's been covered very well, but I just want to talk about maybe some of the cases that I've done. I think that my initial thinking was that this would really shine in the complex cases, and really it does shine in the complex cases. And you'll see later on that not only does it shine in the complex cases, but it shines in the kind of the normal day in and day out simpler cases as well. So this is a lower molar. As you can see, it looks like it, I don't have the CT with me here, but it looks like it's probably a C-shaped canal anatomy. The roots kind of join together, and you kind of lose the canals there towards the end. You have a large apical lesion. And it turns out that I did have difficulty with this case. I had difficulty getting patency, especially on the distal canal. And whenever I encounter these cases, now that I'm utilizing the EdgePRO in my practice, I'm able to go into them with so much more confidence, knowing that even if I have challenges, even if I'm not able to get the same patency as I would like to get in all cases, that the EdgePRO laser is going to kind of make up some of the differences. So this is just kind of a result. I mean, you can see these sizes, they're not super conservative. I think I probably had maybe a 35 or a 40 in the distal, an 06, and probably 25s in the mesials. So nothing super crazy conservative, just kind of my traditional setup. And like Craig was saying, the only thing I did differently here, and this was early on, was I used the EdgePRO as kind of like my final irrigation. I used the water, I used it with EDTA, I used it with sodium hypochlorite, and then I obturated like I normally do. And you can see that I was able to get sealer out the apical exits, and that allowed me to have kind of confidence in completing this case in one visit, whereas in the past, when I had difficulty getting patency on these cases, what I would have done would be place calcium hydroxide into the tooth, or Vitapex, bring the patient back in 4 weeks or so, make sure they were symptom free, and then go back in and obturate the case. Here's a case. This one is an upper previously initiated incisor. You can see that it looks like a challenging one. Again, one of these types of cases that I thought would be an ideal use for the EdgePRO. And in cases like this, where, like in this case, the referring dentist had difficulty finding the canal, I find, and I'm continuing as my use of the EdgePRO evolves, I'm finding that, as Charles was saying, the earlier that it's used in the process, the better for me, especially in the tougher cases. And so in this case, upon accessing and running the laser, it just kind of cleans everything up. And I find that, I mean, I know all of you, I'm talking mainly to maybe endodontists and endo students, and probably some general dentists as well. When you access a tooth, it's just oftentimes, I mean, necrotic cases, vital cases, there's just a lot of gunk in the chamber. And sometimes you have a hard time seeing and trying to kind of get your bearings and navigate the canal, at least to get the process started. And so in this case, and in all cases, by running the EdgePRO within the chamber, it just kind of opens things up, and it helps you see different nuances under the microscope, like changes in texture and color and clues that might point you to the area of the calcification. And so, you know, in looking at this case from the CBCT, I was convinced that I would have an apical exit kind of towards the end of the root here. And I was concerned about the lateral lesion here, but you can see on the final results, I was able to find the canal, and I was able to, again, just utilizing the EdgePRO as a final disinfection protocol, I was able to get some bioceramic sealer to flow out into the lateral lesion, and I basically was able to upgrade the prognosis of this case. The gentleman that I treated this on, he was very, very smart guy, very informed, and he was just super excited to see this result. And I know that he was the type of person that probably went back to the referring dentist, probably said, see, this is, this is why the laser is such an awesome thing, because it was able to get this side lesion filled on my tooth. And that would have been this case right here. Had I done traditional endodontics, this would have been another one that would have been a 2-visit case for me. I would have tried to place calcium hydroxide, probably use some hydraulic forces to pump the calcium hydroxide and try and fill the lateral canal, and then bring the patient back. Upper premolar, this one I knew was going to be a challenge. You could see that there were a couple of roots, and you can almost make out a kind of a third root going off towards the distal here. I was pretty confident in the CT, after viewing the CT, that I'd be able to find the kind of the 2 primary roots, but I didn't know about that distal root. And you can see here, this tooth was missing a cusp, so I left a post-space request of the referring dentist, but I was able to clean and obturate. Again, this was early on. My shapes have gotten a little smaller, a little more conservative as I got more comfortable, but I was able to clean and disinfect the 2 main canals, and then I was able to basically fill the entire extra canal with sealer. And to me, as the others have said, that tells me that by using the laser energy and the laser activated irrigants, I was able to not only be confident that the laser energy got into that area, but that I was able to push some sealer out that extra canal, and again, turn this into a single visit, confident case, and send it back to the referring dentist for immediate restoration. And then this is a case, I wanted to show this one. This is a case from today. So those other ones were just kind of a few that I kind of cherry picked over the last several months. And like, I guess it was Craig that was saying, it's not every case that we get funky lateral canals, although we do see them more often with the EdgePRO cases, but everything just looks clean. One thing is, I guess maybe the scientist in me, is I was kind of like trying out the laser and continue to do so. Sometimes I'll just kind of use my traditional irrigation, my same technique that I learned as a resident and that I had implemented for many years, and then run the laser after and see what comes up, what comes out of the canals when I think I already have them clean. And it's amazing how much cleaner it looks. Again, no long-term studies from me. It's strictly based on my anecdotal experience, but everything just looks clean. And so this case from this morning, I was able to just keep the canals pretty conservative. It's a 2004. Again, nothing super crazy, but just go into this confident that I was able to have a relatively small access, at least small for me, smaller than I normally would have done, because I felt like the laser made up for the disinfection that I wasn't able to kind of visually see by keeping the access nice and constricted. This is, and we'll probably get into this a little bit more in the next discussion, but just kind of as an introduction. So this is a case where I had an external resorption on an upper canine. You can see some screenshots of the CBCT. This is a case that I treated strictly with the laser as far as cleaning and disinfecting of the external resorption defect. So it was all done internally. And by running the laser with the number 3 tip inside the chamber and just kind of letting all the debris and buildup and soft tissue and everything that's kind of sitting there in that resorptive defect, just kind of watching it come up through the access it's pretty exciting. to know that in order to do this traditionally, I would have had to just kind of really open this tooth up and sacrifice a lot of otherwise healthy remaining dentin and enamel on the tooth. And so just kind of some of the results, and I've touched on some of these throughout my presentation, but I've gone from, I was always primarily single visit, but there were cases like, sinus tracts and large lesions and C-shaped canals and difficulty with maybe the apical 1 or 2 millimeters with getting patency, or maybe ledges or transportation of the original canal down towards the end, just anything like that, just kind of the little challenges that we face as endodontists doing tough cases. So those were the ones that I would traditionally do in 2 visits, and those ones I'm doing in 1 visit, in single visit. So almost everything is single visit now. I've had fewer complaints of post-operative pain. I've had fewer patients coming back for us to check things out, say, is this really working? Did you do your job when you did the root canal on my tooth? I'm not prescribing narcotics hardly at all anymore, when I used to pretty regularly on most patients, which is, it's awesome, it's fantastic. The referring dentists that I've talked to have been happy with quick turnaround, which is always something that is a great practice builder. Just for me, I had written down here, increased confidence. I feel better about how my cases are. I feel better about how they look, even though like Craig said, sometimes the final result looks the same, but I feel better. I feel like I've done a deeper and better job at disinfecting and giving these teeth a chance at long-term success. And then I've been able to kind of slowly incorporate smaller shapes. I feel like I'm getting better cone fits with less debris in the canals. And so these are all just kind of really awesome benefits of utilizing the EdgePRO that I wasn't necessarily expecting when I went into it. Just kind of a table to summarize. I don't need to touch too much on this, but it used to be, when I initially incorporated this almost a year ago, complex cases only. Now I think all cases can benefit from the EdgePRO. I used to think it'd be pretty time consuming, and I've noticed that there's not much, if any, increase in treatment time. I'm certainly spending time utilizing the laser, but I think I'm spending much less time doing traditional irrigation, so it kind of balances out. I'm spending less time having to go back in and clean things out when I realize there's maybe some leftover debris or something when I'm trying to obturate. So I think altogether the treatment time has been left basically untouched. And then there hasn't really been much interruption of workflow. I mean, the assistants had to adjust a little bit, moving the EdgePRO from room to room. I work out of 2 operatories with 1 machine, so we kind of move that back and forth. And it takes a little getting used to, but now it's second nature, and it happens very quickly and efficiently. Just kind of some extended applications, things that I want to start incorporating in the future more often is, and we'll get into this more in the next lecture, but maybe utilizing the EdgePRO in cases like sinus tracts, placing the filament into the sinus tract and running the laser there inside the lesion to get to stimulate healing and disinfect. Starting to utilize the apex, starting to utilize the laser beyond the apex in the upper incisor, say with large lesions and open apices, just to kind of get a deeper disinfection beyond the root and stimulate healing. External resorption, I've done it in a few cases, but we're seeing more and more of those in our practice. You may be seeing the same. And then, like Charles and Craig both mentioned, the gingivoplasty and modification of the gingiva for deep interproximal restorations. So again, thanks for your patience. Thanks for sticking with us throughout this presentation. And I think maybe the most important part is taking your questions, seeing where we can help you understand how EdgePRO can benefit you. Maybe if you've been utilizing it, if you're having any challenges, just anything, we're we're happy to help, and we're here to answer any questions you might have.
Great, thanks, Dr. Butler. Great overview, and really appreciate you sharing your experience. And true to form, I do have a question for you.
Yes,
While you're
can you
here.
hear me?
So how versatile do you find the laser for patency, decompression and drainage, recapitulation, etc.?
Yeah, so I find it, can you repeat the whole question? You kind of cut out towards the end.
Yeah, so how versatile do you find the laser for gaining patency, recapitulation, drainage and compression,
Okay.
those types of things?
Yeah, so I mean, I think maybe you're referring to gaining patency on the cases that are tough to gain patency on. So maybe like the calcified cases, probably because I brought up a couple of those cases. So I don't strictly, and maybe the others can chime in if they have different experience. So it's not that I'm strictly depending upon the EdgePRO to get me to length. I'm still using, I mean, there are cases all the time where I'm having to, go through using some C files to do old school hand filing to kind of get all the way there, and combining that with some sort of like the edge, I call it the V taper, the edge V taper, but it's just the Pathfinder, the 1303, I think it is. My assistants know the exact name, but just kind of using a combination of hand filing and some sort of a file to gain patency, and combining that with the laser. So I'm kind of like alternating through the 3 or 4 of the traditional protocol and kind of utilizing the laser in between. And so by doing that, it just seems to kind of like break up, instead of packing debris deeper and deeper into a canal that I'm trying to gain patency on, I'm kind of like removing that debris and allowing the traditional methods of gaining patency to take effect. But I briefly talked about this, but the ability to see things within the chamber, I mean, for me, that's a game changer. I mean, I use it, I love it for like the infamous MB2. I mean, I love running the tip number 3 in there with water for like 20 or 30 seconds. Once I've got the shape opened up, just running it before I do anything else, like Charles was mentioning, and it just opens up, and it's almost like the location of the canals, it just kind of glows white essentially. It's just kind of there. It's almost like a cheat code.
Awesome, that's great. Thanks for sharing. And Charles, I've got one specific for you too, and then we'll go into some questions for the panel. Since you've really popularized and have been really kind of on the forefront of popularizing the mid-root technique, right? With laser fiber, what are your top tips to mitigate ledging? Even for a doctor that is not placing the tip past mid-root.
I guess the maybe 3 things: never activate on your inward stroke. So always activate on the way out. Always have the tip moving. And when you go in and place it, if you feel it contact to structure, pull it back a millimeter and then start on the activation of it. But I mean, now you get that, you develop that tactile sensation. And I mean, now larger canals, I activate in and out. I mean, like I said, you develop that tactile feel for it, that you can handle that. And so, but the main thing is just, if you feel too structured with the fiber, pull it back a little bit and then keep it moving on the way out. And then the other thing is, everyone has their own parameters that they like. And I really think you should kind of stick with what's preset. But I've heard, like one that's 1 watt 10 hertz. If you take a 1 watt 10 hertz in there, I mean, that's 100 millijoules inside the canal. That's a ton of power in there. You're going to ledge. And so you need to be around 20 to 25 millijoules is what I like to be at when I'm inside the canals. So the settings also play, a big factor in that as well.
Yeah, and there's absolutely nothing wrong with using the presets. That's what I use. I've done probably 1,000 cases, almost 1,000 cases with the presets, and it works. Yeah,
that's great.
if I can speak to the ledging thing as well. That was a big fear of mine. I heard these horror stories. You're going to get all these ledged canals. And even with me maybe taking mine a little deeper than Charles, I think it's a concern. You need to be worried about it. Don't go, you will get yourself in a pinch if you're not smart about it. But the little bit of ledging I get, it's not like a ledge like if I did something with a file. It's you can almost just tick right past it. I'll get my rotary file, I can get right around it, and it's instantly smoothed out. So I almost wouldn't even call it a ledge. It's like just a little micro ledge, if you will. I'm not sure that's a real thing, but you get the point. It's not something to be fearful of if you're smart, in my opinion.
Great.
Yeah.
Thank you. Well, I've got a couple questions here. I'll just pose them to the panel here, and whoever would like to chime in and answer. And I'm sure if there are some other thoughts, please contribute. Can you speak to the obturation technique for these cases? Be interesting to see if you guys are all employing similar obturation technique.
I'll go first because I'm probably, in my presentation, I really haven't changed a ton about mine. I'm using the laser as just an accessory to what I kind of was already doing. So I haven't changed a lot. I also mentioned, I think that was one of the reasons I was struggling with pushing my MIE further, is just was operating the canals. I was kind of running into a dead end, that I couldn't get these cases. I could shape them small, but I couldn't operate them to the degree that I wanted them to look good. So I went back and went back to my more traditional MIE type shape. So my shape, my operation is the same as it's always been. Really no change.
To harp on what Craig said and Jacob said as well, I think there's a lot of value to take from clinicians that are in the trenches. And I mean, at least for me, if I had something and I was talking about it and it didn't work, I mean, I would hear about it quickly from, all the cases that we treat today. And I think same that they would as well. And what I hear is, it's easy to incorporate and bring over. And then on the obturation, I've been both sides of the spectrum. I've gone down to the 1403s and I've operated them. I've always used, or 5% of my cases are Kerr EWT sealer, cone fit. I don't squirt a lot of cases because I don't like the control. And that's one of the reasons I, went to the laser, is I wanted to be in control of the case. I don't want any hiccups in the operatories. I don't want any headaches. I wanted to manage it from start to finish. When you're busy, any little hiccup throws your schedule completely off. And then that's when you get frustrated and then the next case doesn't go well and it just kind of snowballs on that. So I want everything to go smoothly. So I cone fit, Kerr EWT. I've gone down to the small cases, but I'm now back to about, like I said, a 20, 2004, 2006 V taper for the smaller ones, maybe a 30 for the larger canals. And the reason is I've done an SEM and I've seen a few other SEMs that were done with these smaller ones, and the middle and coronal looks pretty good. Apical areas don't look that good. When you shaped a little bigger, it looks much better. And then I can tell you clinically what I see feedback from patients, the going just a little larger makes all the difference in, healing. Seems like they heal quicker, and post-op discomfort as well. So I've kind of gone both spectrums, but I'm back in the middle of it. Craig mentioned earlier, we call it root form appropriate instrumentation shaping.
For me, I mean, maybe you're speaking specifically to what type of obturation, but I use a bioceramic sealer. I inject it into the canals carefully without pressure, and then I place a single cone. Pretty simple.
Yep. It's a pretty popularized technique with this approach. So great. Here's another one. What setting and tip do you recommend for gingivectomy?
Well, I'll talk on that. I've probably done the most of anyone here. And I will say, I think there's probably some, excitement coming on in the near future. And, you know, right now the tips are all radial firing. And I think, you know, hopefully in the near future, a side firing, I mean, an in firing tip will come on. But right now the tip is the number 3, and you want to use 2 watts and 20 hertz would be your settings there for that. I'll also say, you know, we talked about some other, you know, while we're talking about lasers, a diode, and I've been doing more and more kind of treatments, and it's a, you know, adding it in as well. There's some pretty good research on it for disinfection as well, targets black pigmented bacteria. So I also have a diode, and actually it sits right on top of my EdgePRO. So I've got the EdgePRO, it does all the cleaning, disinfection, removal, and then if you got a case that's just refractor, you want to hit it with something else, and I've got some pretty interesting cases going on with those. I'm going down inside the canals with the diode, but the diode also works pretty well for gingivectomies as well. Works a little different method than the photoacoustics, works by heat. But for gingivectomy, 2 watts, 20 hertz, 50% water, 30% air.
And on my video today, I turned the water off because it would make, I couldn't make the video. So it was, I typically use water like Charles, but I did it dry so we could see the results there.
The water actually helps, you know, as you know, the primary chromophore for the laser, it's water. And so you have to have a little water. I mean, it'll work, you know, tissue has water in it, but the water actually helps, so I'm told from the smart guys, the cutting efficiency of it.
It's another one here. Do you notice a lot of splashing or aerosol creation when you activate the laser? If so, how do you control that?
I haven't seen it that much. I mean, it's all pretty localized. Doesn't seem to go all over the room or all over the patient or anything, in my experience, at the presets anyways.
Maybe that question too could be a little bit more limited to the Erbium, the YAG laser. PIPS technology has a little bit more of that splashing mechanism. Charles?
Yeah, that one you need to have a, you know, barbershop bib on or something for hypochlorite all over you. But the settings here, if you'll use them, there's minimal splashing going on.
Great. Then what setting do you use in retreatment cases?
I haven't changed my settings for retreatments.
Same.
Same.
I've got, what brand of tricalcium silicate sealer do you recommend for better results?
I mean, I don't know if there's any evidence on one that shows better results than the others. I think for me, the main thing is that you're using a tricalcium disilicate sealer if you feel like that's going to be the best. I've done a lot of cases with BC Sealer and Neo Sealer Flow from Avalon Biomed, and we were talking hundreds of cases with each with the laser and even beyond before the laser, and have had great results with both.
I use AH Plus as my primary sealer for almost all my cases. When I first got the Gentle Wave, I was trying to do more of the single cone Gentle Wave technique, and I was using BC Sealer for that. Worked fine. I just kind of like Charles mentioned with the Kerr, I was trained on AH Plus. It works great in my hands. I know how it's gonna, I know where it's gonna go. It's just what I use. So, but when I use the other, I'll use BC Sealer.
Yeah, I use the Kerr. It's been around. It's time tested. It's been around for 100 years. So I mean, there's more than, you know, thousands and thousands and thousands of cases. Has a little silver in it. Silver's antimicrobial. You can control the flow of it. You can mix it thick or thin. That's why I like it. It's proven, been around.
Excellent. Just a couple more here. Do you guys take any special precautions using the laser with bleach to reduce the risk of a sodium hypochlorite accident?
I've used the laser since 2018 and every case in my partner since 2020. He's been using it every single case. We have not had any accidents. And again, like I said, I use it all day, every day, every single case, full strength hypochlorite. You know, the precautions I use, or you got to know your parameters, your power settings. If you're going to put the number 2 tip in at 1 watt and 10 hertz inside the canals, you better be careful. I mean, that's too much power and you're going to blow it out the end of the root. So you have to know, you know, the settings that you have there when using it. And there's a calibration factor to each of these tips too that you should be aware of. The number 1 tip, you know, it has got a calibration factor of about half. And then the 2 and 3 are almost a 1-to-1 for the power setting on that. So it's important to know that as well. How about you, Dr. Butler or Craig?
I haven't had any, of course, any issues with that. The only thing I can say, I feel like if I have like a large open apex, I'm a little more cautious about leaving the laser firing within the canal. I usually will stay at the orifice when I'm using the sodium hypochlorite, but I'm definitely going to mid-root with water, as I do with all other cases.
Yeah. Same. I actually will irrigate some of mine. I will actually use EDTA as the agent if I'm concerned that I'm going to have any issues. I did have I didn't know the reason. I'm kind of learning from Charles as we go. I was using the 2. I mentioned in my talk I've moved more to the 1, and I think that's probably unbeknownst to me. I was probably a little more powerful than I needed to be using the 2. I was getting a little bit of patients were feeling it, things like that. So I think I was getting a little more energy long than I realized. And so since I've switched to the 1, I've really had no issues with taking that a little deeper into the canal.
Yeah, Jacob, good point on the open apex case. I don't use hypochlorite like a young kid, trauma, tooth, 8 or 9. There's actually a study out of University of Washington. They did water only and used the water only, and then they dried the canal. And on these, you know, we're not where the laser light can go everywhere. And so there's studies that show you get up to about 1 millimeter penetration of the light into the dentinal tubules after you remove the smear layer. And so then they dried it and they did dry mode on there, and you know, they cultured it and everything. So some of this you got to take with a grain of salt. But the water only on the study that they did was as effective as hypochlorite on those types of cases.
And another point with the open apices, I go into these cases with way more confidence now after using the EdgePRO, because I know the laser is doing work that I'm afraid to do with traditional irrigation and the sodium hypochlorite. I mean, I'm always cautious with these cases. And so, you know, you're kind of left wondering, well, am I doing anything in the apical third with my irrigants because I'm being so careful? And if I'm running the EdgePRO with water, I finish this case with a lot more confidence than doing traditional irrigation.
Good feedback. How do you use with a fistula?
Chris,
I haven't done it.
can I share my screen real quick?
And what?
Do you mind if I share my screen real quick?
Please. Let's make you the presenter here.
Oh, let me see here. Okay. Sinus tract case here. Can y'all see this?
No, we have a blank white screen, so maybe we may need to do the preference setup again. We've managed through this a couple times now.
How about now?
Nope.
Well,
Oh, now we can.
No.
Good now?
Yes.
Yeah.
Okay, so get this off my screen here. Sinus tract, patient presented sinus tract. You're going to use the number 3 tip, 1.5 watts, 30 hertz, about 50% water, 20% air. You're going to insert the tip into the sinus tract or into the endoperioral pocket, and you're going to activate just like you would on endo on the way out. Do that 3, 4, 5 times. Then I like to go and just kind of paint over the gingiva, and you're going to put a little kind of what we call a bandage over that, and it's going to kind of get wide over that. So that's what we did with this case. And post-op, and then this is 1 week following treatment here. So I had the patient back for 1 week treatment. It's pretty simple. You just put it in there, step on the gas, and pull it out. Be aware of any, you know, if you're around the mental or anything like that, be aware of anything like that. But I mean, I do that on endoperio defects, sinus tracts, anything like that.
Charles, I've been asked, can you repeat the settings for the sinus tract?
1.5 watts, 30 hertz, 50% water, and about 20% air.
Great.
Number 3 tip, don't use the number 1, it's too small. You'll put it in there and you'll break it in there. So number 3 tip only.
Well, we're coming up on the top of the hour here, and what a great interaction. And this is of course part 2, and we've got one more, part 3, and I think we had a little bit of a foreshadowing into what we want to talk about for September 14th, which will be looking at more challenging cases with EdgePRO and how do you increase predictability. All of you as specialists and excellent in the work that you do are always every day trying to look at ways you can increase your predictability in results from your cases. And so we'll look at that with an eye on more challenging types of cases. So we'll have, certainly our same panel here with Dr. Maupin, Dr. Anderson, and Dr. Butler, who tonight have been gracious to share their time and experience. And I know, as always, I learn a lot in speaking with them all. So appreciate your time as faculty and joining us this evening. And I appreciate everybody who's been online watching this. We find this an effective way to communicate. Hope everyone's having a great summer, balancing a little bit of work with some fun with family and friends. So we'll continue this in a couple weeks for part 3 as we close out our summer series. But I think we'll call it an evening tonight. And again, I wish everybody a great night. Thanks for your support, and we'll talk to you in a couple weeks. Take care now.
Thanks.
Bye, everyone. Thanks.
Night.